So, on part two, we like to discuss another mysterious injury that is often missed in the world of personal injury, and that is CRPS, complex regional pain syndrome. This is a very painful, detrimental injury in the personal injury world. Um, it is, as I said before, misdiagnosed or missed, and we kind of want to bring some light to it, how to diagnose it, how to treat it. It's very important because, from my own experience with these patients, it really overwhelms their lives with immense amount of pain, which then causes an immense amount of psychological pain. And it is extremely tough to treat, and specialists like Dr. Taimoorazy, a good portion of his practice, treats and diagnoses these type of patients. So, Dr. Taimoorazy, please enlighten us about CRPS and tell us what are the symptoms and how we can treat it, and what are the forms of treatment that you use in your practice on a day-to-day basis.
Thank you, Dr. Nick. CRPS, or complex regional pain syndrome, is a very poorly diagnosed condition, and we take pride that at our practice we are extremely aggressive, and we actually look for this condition because the signs and symptoms of a CRPS can sometimes be subtle, and if you do not catch this condition, if you do not diagnose this early, can result in devastating, almost irreversible injury to the patient. As you mentioned, this is very common in personal injury, in traumatic injuries. Could be a motor vehicle accident, could be a work-related accident. At any rate, basically what happens is when the extremity has
What kind
been...
of accidents?
So
What are the different types of accidents that can cause this, and it's apparent?
Yes, there are two different types of CRPS. By the way, CRPS used to be called RSD, reflex sympathetic dystrophy, because initially we thought that it's the abnormal sympathetic nervous system function that is causing all these symptoms and disturbances for the patient. But as studies developed and we looked more and more into this condition, we learned that it is just not only sympathetic nervous system. There are many other factors involved in causing this condition. So CRPS has two types, type 1 and type 2. Type 2 is a little bit less frequently encountered, and that is when you have a severe nerve injury or disruption, such as if a patient experiences, for instance, brachial plexus injury, or if during an accident a nerve is completely shattered and damaged.
Can you describe an accident that can cause that, doctor?
The typical brachial plexus injury would be a person who is on motorcycle, for instance, and falls off, and as they roll, for instance, and as the arm gets extremely stretched, the brachial plexus, which is basically in your armpit and in your shoulders, that gets stretched so much that basically the nerve is torn, to put it in simple terms.
And the other type, which is the crush injuries,
Yes.
what is that mostly like?
So the other one, crush injuries, would be, for instance, if you're again in a motor vehicle accident and the car, I guess, is so damaged that your arm is crushed, your foot is crushed,
Broken arm, broken femur, broken leg,
any extremity
any
damage.
extremities that
Yes.
you have a crush injury. Very important. And
Yes.
we've all seen those in the personal injury world.
Now, it is interesting that some of these CRPS cases happen after a surgeon has attempted to correct an injury, and without any poor outcomes of surgery specifically. Like the surgeon did the best surgery ever, There is no problem with that. But the body, how it reacts to that surgical intervention, can trigger the start of a CRPS. So it is not that the surgeon made a mistake or anything. They did the perfect, the most beautiful surgery. They corrected the fracture, they corrected the knee injury, the meniscus injury, for instance. But then suddenly patient starts developing a pain that is completely unfamiliar to that person.
So it can be from a post-op
Yes,
surgery. Okay, that's
absolutely.
very interesting. Yes. Okay.
Absolutely. It is basically explained by almost every patient that this is the weirdest pain. I've never experienced a pain like that in my life. It is burning. It is lancinating. It is boring. It is so weird that the patient has trouble even describing the pain. And that is typical for a CRPS pain. With that comes other findings, such as swelling in the region of injury of that extremity. Color or temperature changes are also some signs or symptoms that are associated with this. And then trophic changes, which means changes in the rate of growth of hair or nail in that extremity can be also seen. Now, what we're now discussing is the, I guess, textbook case of a CRPS. And you should really not wait for a patient to get to those to that situation. That kind of will be maybe a little too late, because CRPS can cause ankylosis in that extremity, which means if you do not treat this condition properly and early, then the range of motion in that extremity becomes significantly limited and becomes like a frozen extremity pretty much. And it's very hard to reverse that, even with most aggressive physical therapy and pain management interventions. Still, you may not be as successful if you had picked up on this condition early and if you had intervened early. That's why in our practice, we actually are actively looking to rule out in any extremity injury, whether it is post-surgery, post-trauma.
That is exactly right. And with my experience, and that's why there is certain doctors that can pick this up. With my experience, most of the physicians relate this to a disc herniation with sciatica and radicular pain, whether in your arms or down your legs. It's misdiagnosed with radicular pain. And this is why it's so important to go to a subspecialist that can pick and find this type of condition.
Absolutely. And as with almost any medical condition, early diagnosis is paramount, but especially in this condition, because as we said, if it's misdiagnosed and if you let it continue, reversing it would be a very difficult task. As I said, the signs and symptoms could be textbook or could be very subtle. A patient may only complain to you from a little bit of a decreased range of motion, for instance, in an injured wrist, and a little bit of swelling, which most people, most physicians may attribute that to the injury, to that actual accident. But any injury has a lifespan, and that extremity should heal, let's say, within 4 to 6 or 8 weeks. If you are 8 weeks, 10 weeks post-injury, and there is no, let's say, remaining pathology, but patient continues to have weird pain in that extremity, if there is subtle swelling or decreased range of motion, that could be the telltale sign that this may be a mild form or start of a CRPS, and that is when you will be gold if you intervene at that stage.
Okay, great. So now we've diagnosed it, we found it, we see the symptoms. Now, here's the tricky part. How do we treat it? And talking to Dr. Taimoorazy, there is two options that seem to work well with CRPS. The first option is ketamine that we talked prior about, and the second option is spinal cord stimulators. And I'll let Dr. Taimoorazy first talk about how ketamine use helps CRPS.
If I may, Dr. Nick, once we come across a patient that we highly are suspicious of CRPS, initially, some of these patients may respond to anti-epileptic or antidepressant medications, which may help some of them if they would to tolerate these medications. If they fail, even if the area that is involved is very, very small, we may even use compounding cream, which is a cream that I send order to a compounding pharmacy for a cream that will contain also, interestingly, ketamine. And if that is used in a small area, that may be helpful. But unfortunately, most patients have a large area that is involved. So application of a compounding cream pretty much becomes not practical. So then we resort to, as you mentioned, medications, which again could be a miracle for this patient, which will be ketamine. For this instance, the dose is not anymore sub-anesthetic. The dose is slightly larger. Still is not at anesthetic dose, but we need effectively to block the NMDA receptors with a higher dose of ketamine. And that usually requires about 1 milligram per kilo. Still is about half to 1/3 of the anesthetic dose, but still it will be given to them over 60 to 75 minutes, and they will be basically with us for that period of time. And again, they will not be under anesthesia. It's absolutely not even sedating to that extent. But the dose is slightly higher, or from what we would to use for PTSD, depression, or anxiety after traumatic injury, traumatic brain injury. So that.
How long is the duration, depending on the severity?
Yes, depending on the severity, this may need more repetitions. There is really no standard. There is no. Some patients may respond to sometimes 2 or 3 infusions. Sometimes it may take 6 to 10 infusions, but almost every patient responds, because clearly the pathophysiology of a CRPS is a very augmented and a process that is called central sensitization in the central nervous system, which means your brain or the tissues that are processing the pain have become extremely sensitized to this whole cascade of events that is causing the pain. With ketamine, we break the cycle. That is the beauty of this medication. So without use of any opiates, because nowadays, unfortunately, as we see, still some physicians are putting these patients on a lot of opiate drugs, which quickly can make them dependent, or, as we know, there's so much problems that we have with opiate medications. But ketamine can effectively go to the root cause, and that's the beauty of what we do. We are not putting a band-aid. Like you give them opiate, is like you're putting a band-aid, and you have to continue the opiates in order for that patient to be even remotely, maybe moderately comfortable. However, when you use ketamine, you are treating the root cause. You are addressing the central sensitization that has occurred in their brain and in the nervous system, and you desensitize the brain and the nervous system from this cascade of events that has resulted in CRPS. So you treat the root cause and you take care of the patient beautifully and with a very safe medication.
Wonderful. And the second treatment?
So there are patients that if they fail medical management, whether it is the anti-epileptics or antidepressants, ketamine, physical therapy, and this I should emphasize, the reason we are so aggressive in CRPS is to take care of the pain so aggressively so patient can resume aggressive physical therapy, because that is ultimately what it takes for patient to overcome that injury. But most patients cannot do physical therapy because it hurts. They can't even move that extremity. So we take care of the pain. The patient starts the aggressive sessions of physical therapy, and soon they're fine. So, but there are some that they don't respond, and there is a procedure that is FDA approved and has been around for a long time. And one of the best indications for this procedure is CRPS. The procedure is called spinal cord stimulation. Spinal cord stimulation is based on an interesting phenomena. Like we all know when we bump our elbow or knee against the door or the wall, the first thing we all do, we start rubbing it very hard, very deep, like massage, and within seconds, pain starts subsiding. Why it happens is when you're massaging that area of injury or where it was traumatized, you're actually stimulating large nerve fibers. So, and that has been demonstrated based on a theory that is called gate control theory of pain. So when you stimulate large fibers, which is like when you massage the area that you hit against the door, you are actually interrupting transmission of pain, which happens in the small nerve fibers. So stimulation of large nerve fibers inhibits transmission of pain in the small nerve fibers. And this happens at spinal cord level in the dorsal part of the spinal cord. So this technology, spinal cord stimulator, takes advantage of that concept of stimulating the large nerve fibers that are incoming into the dorsal part of the spinal cord. When you stimulate the large fibers, pain is controlled. And very, very simple procedure. A lot of our...
So what is exactly a spinal cord stimulator? I think you brought in a model today.
Yes.
And we can kind of show our viewers what a spinal cord stimulator looks like. It looks like a very small battery, and I think it is a battery, that helps give some of the patients relief. So please tell us how the mechanism works.
So a lot of our audience may have heard of epidural injections. A lot of ladies get epidural for their control of pain of labor. So it's a very, very routine, very simple procedure. The beauty of spinal cord stimulation is it goes into two phases. Phase one is the trial. So patient is not committing to anything that is permanent. Patient can test this treatment and see how this treatment is actually helping and by how much. That's the beauty of spinal cord stimulation trial. So during the trial, what we do, when the patient comes, we give them almost a very light sedative because it's such a minimal procedure, despite that the name is, I guess, a little complicated or maybe scary, that people may think, oh, he's dealing with my spinal cord. No, it's not. It's absolutely not the case. It is a simple epidural procedure, just like a lady in labor department gets an epidural placed for them. This is exactly like that. It's even, of course, less painful because it's done in a very controlled environment. Patient is relaxed, maybe slightly sedated. So we, with a very small epidural needle, we get into the epidural space first. And then instead of injecting steroid or putting the catheter that is used in labor department, we put these, I'll show you, you can see a part of these wires that are kind of sticking out here.
And we refer to those, I believe, as leads?
Yes. So these leads that are entering the spine through this opening, at their tip, they contain, I don't know if you guys can see it. So each lead at the tip of it has contacts, and these are called active tips. Active tip is basically where that electrical stimulation, which can be in the form of, literally speaking, millions of different programs that can be delivered to these contacts, they in turn start stimulating the large nerve fibers in the dorsal part of the spinal cord in the epidural space. So we're not even in the spinal cord. We're not anywhere close, but close enough that we can stimulate these large fibers. By using these contacts, when the electricity is delivered, we ask them to tell us where they feel a sensation of tingling or vibration. That's what the patient initially has to feel, because we are using this sensation so that the patient tells us if we are successful to provide coverage in the area that they feel pain. For instance, if they have back pain, if they have leg pain, or CRPS, let's say, has involved the right knee, for instance, we will place these leads in the area of dorsal backside of the spinal cord that corresponds to that area that is injured. But in order to be absolutely precise, we need a patient's feedback to tell us that they are actually feeling a tingling or vibration sensation in the area that they have pain. So that means that we found the area of the spinal cord that corresponds to the area that is painful.
So the step one is a trial, and during the trial, you put in these leads. The patient gives you feedback. How long does the patient? How long does the trial last? When the patient goes home with a device before the permanent implant?
So the best is usually we ask the patient to use this technology for roughly about 4 days. Now, if a patient gives us a feedback that I have 100% pain relief and I'm very happy, this is working, this is amazing, we may even remove this after 2 or 3 days of use. Because the longer it stays there during the trial, there is a slightly increased risk of infection, which we don't want that, of course. Patients stay on antibiotics while they have the trial leads in place. So the risk of infection is almost none, but the longer you keep it, because some places they like to keep it for 7 days, for instance, which I honestly don't think is necessary. If after 2 or 3 days of use, patient gives you 100% confirmation that this was effective, we just take it out.
And once they give you the confirmation, what is an implant? Is it very invasive? Where do you put the battery? Please take us through that.
So during the trial, which we said it's about maybe 3 days, the leads are placed. Then on the back of the patient, there is a dressing that covers all of these wires and leads. So it's all protected. Patient is really comfortable. They just should not shower. That's all we ask. At the conclusion, if they are happy and if we say, okay, this worked, they come back to the office, we pull the leads, doesn't need any sedation or anything, it's nothing, patient doesn't feel anything. We pull the leads, put a band-aid. We have to wait roughly about 6 weeks from trial, if it was successful, to putting a permanent implant. That's the next step. Permanent implant is exactly the same procedure. The only difference is this time the wires that we have placed, now we have to anchor them or stitch them so they won't move or they won't come out. The stitching, nowadays there is a very advanced technology that automatically stitches the system. So it's not like putting like the cumbersome, technology that is used to stitch tissues and stuff like that. So patient, again, is slightly sedated. These are all procedures that are performed under minimal sedation because they are really minimal. The size of an incision to place these leads is probably about an inch or so. We have to make another incision to accommodate the battery that should power the system. And if the camera can zoom in onto the battery, this battery is just, if people are familiar with a pacemaker battery, for instance, it's more or less the same size. The battery is placed usually under the muscles in the buttock area because they are thick, big muscles. They can easily accommodate such a small device. And once the system is implanted, it's pretty much like permanent. Okay, and maybe in 10 years you may need to go back and exchange the battery. The beauty of the system is it is controlled by a remote device. You can turn it on, you can turn it off, you can change intensity and feed different programs into that battery, which is not just battery, it's the brain of the system. It's called IPG, internal pulse generator. So you can feed different programs such as increase stimulation, decrease stimulation, change the pattern of stimulation to how the patient likes it to be. So it can be a sensation of tingling that covers the painful area all the way to no sensation, because what patient feels depends on how fast is frequency of stimulation in the contacts of the spinal cord stimulator. So if you're stimulating high frequency, you don't feel anything, but you don't have pain. If you stimulate slower, then you have that sensation of buzzing or tingling, but still covers the pain. So it is interesting how patients choose the sensation that is good for them. Because some patients, when they stimulate at high frequency, when they don't feel any stimulation, they think maybe the machine is not working. Despite that they don't have pain, they feel like, you know what, I want to feel something that gives me assurance that the machine, the system is on, and of course I don't have pain, I have minimal pain. So that's the patient's choice, how they stimulate the dorsal part of spinal cord. The battery, of course, like any other battery, slowly runs out of juice, right? So it remotely is rechargeable. So that it connects with the device with radio frequency technology. So let's say you are watching news or a movie at home, you just put it on your back, and remotely it connects with it, and within half hour to hour it recharges it fully.
The battery, yes.
So it's an amazing technology.
Yeah, you become bionic, like the
become
$6
bionic.
million man from our era. Now, unlike most surgeries, permanent spinal cord stimulator is not so permanent because, if Dr. Taimoorazy can chime in here, it is a reversible surgery if a patient does not want it later on in life. Can you take it out, Dr. Taimoorazy?
Yes, absolutely. The beauty of all of this and almost everything that we do in pain medicine and interventional pain medicine is that we do not disrupt your anatomy. Like if you go, for instance, for disc herniation surgery, the surgeon has to remove the disc, which sometimes they have to, because if their condition is so bad that the disc is pinching the nerve, almost nothing else would work. But ultimately, your anatomy will be disturbed. Sometimes, in order to stabilize that disturbance that was created by surgery, then they have to put hardware, like they have to put rods or screws to maintain a reasonable stability of your spine. With our procedures, we do not change your anatomy. It is as is when you were born. It is just we go to the root and the source of your pain, the root cause of your pain, and targeting those structures. Like almost, it's like a completely futuristic approach. Sometimes I really, when I'm doing these procedures, I wonder how much can we achieve by just attacking and directing our needle to that source of the pain and come out without touching anything else. And it's like you're back to normal, pretty much.
Not to interfere with the structures.
Not to interfere. That's beautiful.
Wonderful. And after the permanent spinal cord stimulators, in your experience, when it comes to CRPS, what are the benefits as far as what percentage, in your experience, feels immediately better or through time better? When does it really kick in?
The impact of spinal cord stimulation is immediate. I mean, as you stimulate the dorsal columns, the back of your spinal cord, which corresponds to where you have pain, you control the pain immediately. It's not cumulative. It's a little bit different for occipital nerve stimulation, which we do for the most difficult to treat headache disorders. Occipital nerve stimulation, the results of it is cumulative. So initially you may feel not much, some relief maybe, but after 6 or 12 months of use, you will notice it's getting better. It's getting better.
But for CRPS, it's immediate.
It's immediate.
Wonderful. Well, thank you, Dr. Taimoorazy. I really appreciate your time. And that concludes our episode on PI Today. Thank you for joining us. We will have, in the future, more physicians and doctors on this show. And have a great week. Stay healthy and drink your juice.